So we'll just take maybe 5 minutes or so to discuss. And one of the questions that I have with regards to, and maybe Bassem and Joaquin can talk about this, is when is a reasonable time to use the technique of a lower trap transfer versus using latissimus transfer to restore external rotation? And do you have some type of algorithm? Obviously, you can probably do the lower, in the setting of doing proximal humeral allograft, you can do a lat teres transfer, or at least the latissimus. But is there something else that makes your decision besides happenstance?
No, I think to be very, very, very honest, I have a very limited experience with the lower trap in the setting of revision reverse. So my go-to transfer is the latissimus dorsi, because in primary it has worked really well in my hands and in revision as well. So when I think about a lower trap is when I know that the amount of proximal humerus bone missing makes me think the lat dorsi has been detached for a long time, and I will probably don't find it. And then it's when I go to the lower trap issue. So this technique is very nice, and you guys asked me to present it, but the reality is that we don't have any data.
Sure.
Like I have 4 patients. I'm sure that Asken has more, but I only have 4. So I don't want to send a message that that is my transfer of choice. It is not. It's just that because yesterday we presented a video on the latissimus dorsi, and I only had 5 minutes. I didn't have time to show both.
Sure.
But the most common I use is a latissimus dorsi transfer in revision also.
Okay. And Bassem, any addition to that? Or?
For any patient who come after reverse done and they have no ER, I do lower trap on them. Specifically if they are worried about internal rotation. Because like if the patient coming already, I have a patient that presented yesterday, he came, I told him, we can improve it. He told me, what about my internal rotation? Like even now it's limited, can you get it better? So he wants me to improve external rotation and internal rotation. And I try to explain to him, it's not easy to explain to the patient how difficult it is. I told him, no, but I will try to do my best not for you not to lose internal rotation. In this setting, I will try to do the lower trap, save the latissimus in case you need more internal rotation for the future, or even I transfer it at the same time. But I don't try not to do it at the same time. I do PECT, lower trap, and latissimus is a backup, and I tell the patient about it.
So for you, that means...
Can I ask you something, because we're learning from each other? In many of these patients, there is no greater tuberosity by the time you do the revision. So are you okay to attach the Achilles allograft lower?
That's an excellent question. That is, I determine at the time of surgery, because no, it's too much low. It's too low is not very good. This is why if you look at the latissimus anatomy in the setting of reverse, it's very, very tricky, by the way. Because yesterday we had a lot of discussion about it. If you look at the latissimus, how it's coming around, it looks nice, and it many times the orientation is changing. And what is it doing exactly? Is it tenodesis or really doing it may be doing external rotation, but many times it is like you need this flexion in the reverse, you need internal rotation, and you're bringing very powerful muscle from the back to give you this external rotation. You're trying to preserve these two. And we're still trying to figure out all the parameters to give you the best reverse. So it makes me still worry, except in a very nice setting when you have, like yesterday, Jay showed the case. It was perfect, right? You have a massive, and I very rarely ever do lower trap in the primary setting. I always do latissimus. And revision, I will do it. If I need, I will add the bone graft like what Joaquin did.
And the reason, again, just to make that clear to people, is because in the revision setting, typically there is no subscapularis at all, and your concern with doing any type of, say, latissimus transfer or lat teres is in the setting of with someone with no internal rotator, you're taking their only internal rotator
That is
away.
one reason, and the other reason, biomechanically, the lower trap is way much better.
Okay.
But this is one of the 2 reasons.
Okay.
I would like to defend the latissimus dorsi because we publish many papers regarding that. If you have a good subscapularis, if you have no teres minor, and if you do reverse purchases, you do episcopo, and it's worked very well, very well. Mm-hmm. We have many papers. I think that is completely different than the complex cases.
Sure.
This is very complex cases, and lower trapezius is a good choice. But we have a place for latissimus dorsi.
Mark, and then April.
I had a question, but also a comment. So, when you have proximal humeral bone loss, the biggest complication is instability afterwards. And if you have nothing in the back, so you don't have a horizontal vector. So for me, I've already had some instability with pulling the lat too tight to restore external rotation in primary cases. So that to me was really awesome, because I think that will help provide stability because now the vector of pull of that will provide some horizontal force pulling it in. And the question, I guess, Joaquin answered, but when I use the proximal allograft with the allograft tendon, which is my procedure of choice for severe bone loss, I like to sew the tendon of the subscap to the subscap itself, and usually you can do that. They might have some loss, but you make it up with the allograft. So if you do that, do you then still do the pec transfer?
No, sorry. So again, if the patient has a robust subscapularis tendon, I would repair the native subscapularis to the allograft because it's a perfect muscle. But in many of these patients, the subscap is nowhere to be found. And what we are trying to figure out with cadaver studies is if you then move the pec up to a better location on the lesser tuberosity through the tendon stump of the allograft subscapularis, probably you have a better vector for internal rotation as well. And it's a constrained implant, so the pectoralis major is not going to dislocate like an anatomic because it's constrained.
Add one more thing for this one. We talked about revision and about dislocation, and just keep it in mind when you're doing a case and trying to stabilize the reverse and putting a powerful muscle with an inferior pull. That's it.
April?
Real quick, I'm just going to add to John's discussion. So great tip about the cannulated hip system. But I'll tell you, to freehand that threaded K-wire under fluoro is extremely difficult, and you get kicked out all different ways. So one thing that I realized during a difficult case is that if you take out the cement in the front, and if that cannulated reamer, it's about 8 millimeters, and it's about the width of the shaft. If you put it in there, that is a perfect straight graft, and it won't allow you to kick out. So the wire isn't able to bend as much. So it actually acts as a guide to allow you to get that straight shot straight down through the cement, so you're not kind of veering all over. So I use that almost as a guide and it's really stout. It fits right in that canal, and I found that really can be helpful. And you can then drill right underneath that cement restrictor, and you can use then the sentinel reamers. And you can gradually ream over time, copious irrigation because you're going to create heat. And then you can even get some type of backslap instrument underneath that once you've done that to really try and bring out that cement.
Jonas here, but that tibial nail set also has like a guide that'll go deeper and then guide your wire straight down the center. It'll be more of the diameter of your proximal shaft so you don't get kicked out by the guide wire too.
I think there are, if you kind of go in the boost, there are some systems that are available that actually they're specifically designed for this process. I think we'll go kind of move on to the next kind of set, and actually